All right, hello everyone. Thank you for joining us and welcome to the Collaborative Genomics webinar series. This is the first in a series of 3 webinars co-coordinated by the University of Wisconsin and the Cancer Genomics Consortium. My name is Caitlin Lenhart and I am Assistant Director of Cytogenetics and Molecular Genetic Services at the Wisconsin State Lab of Hygiene here at UW. For those of you joining us for the first time, this 3-part webinar series is being held as part of the UW Collaborative Genomics Conference. It's a monthly web-based case conference hosted by the Wisconsin State Lab. This platform brings together laboratorians and clinicians from across the country and world to share interesting and unusual patient cases in the field of medical genetics, as well as to educate one another about current and advanced genetic and genomic diagnostic technologies and guidelines. We aim to keep attendees updated on overall genetic knowledge, to enhance communication of genetic information across disciplines, and to ultimately improve clinical laboratory practices for enhanced patient care. It is open to all individuals in the field of medical genetics and genomics, including but not limited to physicians, genetic counselors, lab personnel, residents, fellows, and students. If you are interested in attending the Collaborative Genomics Conference or presenting a case in the future, you can contact Lori Halverson for details, whose contact info you can find on your screen. This case conference, including this 3-part webinar series, offers attendees AMA PRA Category 1 credit. In order to receive this CME credit, please text the code to the phone number listed on your screen. You are required to have an ICEP account through the University of Wisconsin prior to the seminar in order to claim credit. If you have not registered for an ICEP account and would like to do so, please contact Lori Halverson for assistance. You can also find ICEP registration information on the CGC website. We highly encourage registration for all attendees as it also helps us track attendance. And speaking of attendance, there are several attendees for this webinar today, so we do ask that you please keep your microphones muted. If you have a question for our speakers, please type it into the question tab of your webinar control box. We will then address as many as possible during the Q&A session at the end of this webinar. With that, I will turn the mic over to Dr. Gordon Araka, Chair of the CGC Education Committee, to introduce our first speaker.
Thanks a lot, Caitlin. I would also like to welcome everyone to the first webinar in our pilot series. The lectures in this series will focus on the topic of new methods for detecting structural genomic variants and on interpretation of copy number abnormalities in cancer. So we elected these topics based on the survey that was conducted by the CGC Education Committee to determine educational needs and interests of our members. And we certainly hope that these topics will be of interest to you and would like to invite you to check out future lectures in our pilot series. So we are very excited about offering these lectures in partnership with the Collaborative Genomics Conference. It has been really wonderful working with their team on organizing this webinar series. We want to thank them for letting us use their regular conference time slot for these lectures. Also for being our webinar host for today and for providing us with a mechanism to offer CME credits through the UW ICEP. I also want to thank all the members of the CGC Education Committee for their hard work on organizing this program and CGC leadership for supporting this project. But my special thanks go to our today's speakers. We are really grateful that in these challenging times, they took the time to prepare their talks and to be with us today. So it is my great pleasure to introduce to you Dr. Brynn Levy and Dr. Rashmi Kanagal. I will introduce both speakers at the beginning, and we will just switch between their talks without interruption. So Dr. Levy really does not require introduction to the CGC members, and he is one of our past presidents. He has been a consultant at the CGC board for many years, but he also has a real job when he doesn't contribute to the CGC. He is a professor of pathology and cell biology at the Columbia University Medical Center and medical director of the Clinical Cytogenetics Laboratory of the New York Presbyterian Hospital. His interest has been in implementing novel genomic technologies in reproductive medicine. He pioneered using chromosomal microarrays in prenatal setting and IPS, and more recently, optical mapping, which he will be talking to us about today. And our second speaker is Dr. Rashmi Shamanna. She has also been a long-term member of CGC and is currently serving on our board of directors. She's associate professor in the Department of Hematopathology at University of Texas MD Anderson Cancer Center. She also serves as the director of the microarrays facility in the Molecular Diagnostics Laboratory. She's board certified in clinical pathology, hematopathology, and molecular genetic pathology. Her primary research interest has been in application of novel molecular techniques to understand pathogenesis and guide therapy of hematologic malignancies. So she will be telling us today how she has been using optical mapping for comprehensive genomic characterization of hematologic tumors. So with that, I welcome you again to our inaugural joint webinar, and I will pass the mic to our first speaker, Dr. Levy.
Well, thanks very much, Gordana. It's really exciting to be part of the first CGC webinar series together with Rashmi. Start off with my disclaimers. And I'm going to hopefully introduce you guys to the whole concept of optical mapping. It is something extremely new for cytogeneticists and clinical geneticists. In a way, it's very similar to karyotyping because it is a technique that directly visualizes very long strands of DNA in their native state. You get consensus assemblies, which are then used to accurately call structural variation between samples and the human reference genome on a genome-wide scale. And don't worry, I'm going to spend quite a lot of time showing you animations to try to give you a good understanding of how this works. The important thing is that it gives us a resolution when compared to karyotyping, which is something we know very well. We're talking about a 1,000-fold increase in the resolution. And so that makes it extremely well suited for mapping complex balance rearrangements, their breakpoints, and as I'll show you, it also gives you information about copy number. So how does it work? Well, the first thing you need to do is extract long DNA molecules. And the important thing that you understand is that this is a very different extraction to how we would do for traditional molecular analyses, say for cystic fibrosis, microarray, NGS. The extraction protocol is very specific. You'll end up directly labeling and staining DNA at specific sequence motifs. So you're introducing these, in this picture, these green kind of fluorescent tags. The labeled DNA is loaded onto a chip and the instrument, and then the DNA linearizes as it moves through the nanochannel array. So what you see is it starts off first in its native state as a Gaussian coil, and then as it gets loaded onto the machinery, it moves through a microchannel where it's partially elongated, and then ultimately it gets drawn into these nanochannels where it becomes singular DNA molecules. And here you see what the instrument looks like. Over here, the Gaussian coil will start up on kind of this lip, and I'm going to show you a very cool video that shows this in real time. So it starts off on this lip on the left, and as it gets pulled through the microchannels and these pillars, it starts to elongate, eventually coming into the nanochannels and gets linearized. And this is what the actual nanochannels look like on that far right. And as I'm going to show you now, this is what the individual DNA strands look like. And here you can see those green tags that I mentioned as part of the extraction and labeling protocol. Here's a nice blow up of what you see the individual DNA strands looking like. And the video where you can see on the far left, imagine that lip where it's in the Gaussian stage, and here it's kind of going through those microchannels and those pillars, and then eventually going into the nanochannels where ultimately you'll see, as we right here, those individual DNA molecules, which is pretty amazing. So The raw data, remember, as I said, it's similar to karyotype in that we're visually looking at the entire genome. We're looking at it in its native molecule state as long expanded DNA strands. You take the raw image data and you convert it to digital molecules. So here you can see those digital molecules. We aggregate them and assemble them. And you can actually pretty much assemble a whole genome de novo just by aggregating and seeing where you have the overlaps. But ultimately, we want to compare this to reference genomes, which is what we do. People always ask, well, how does this improve the resolution compared to G-banding? And to kind of give you an idea of the difference in resolution, I'm going to start off with our G-band. And so when we talk about G-banding, we talk about our bands at different levels. Typically, if it's at 400 band level, which very often we look at our cancer specimens at, that means each band is a single data point. We count up all the bands on a karyotype, we get about 400. And here, if I'm just using 6q22 as an example, there we see what it would look like at the 400 band level. As we stretch out our chromosomes, we get more bands. So each subband now represents an additional data point. And here we pull Q22 out into 3 separate subbands. When we go to the 700 band level, we now get even further information. So we get Q22.1 all the way to 22.33. So we know and appreciate it's unlikely for us when we study cancer samples to be looking at it the 700 band level. We're more likely looking at it the 400 band level. Well, imagine us looking at that 1,000 times greater, which is essentially what optical mapping is doing. So here, each band is very small, as I'm showing you there, but ultimately, you can imagine those bands now being represented by literally thousands of additional data points. And that's exactly where we get each kind of band pattern. So how is the analysis done? And I want you guys to get used to this type of image. So in this illustration, the patient DNA is seen in blue at the bottom, and we have a reference map. So if we look at the tagged sites at the patient DNA, what you'll see at the bottom left is that it matches beautifully to a reference genome specifically at chromosome 5, and even more specifically at those positions, kilobases as illustrated over there. On the right, we have the DNA fragment that now matches to another part of chromosome 5. And what you'll see is that that region in the middle is missing. Now, what I actually did for illustration purposes is I digitally kind of cut that individual or single DNA molecule, when in fact, this is what it looks like. So it's a single DNA molecule. And now if you kind of map those bands, you can see that it maps to everywhere on chromosome 5 except for that middle region, which is seen as a deletion. So in a similar way, you can map multiple types of structural variants. So here you can see a deletion, as I showed you in the previous slide, but we can also see insertions. You can see that the patient DNA is represented multiple times, either as a tandem duplication as seen at the bottom middle, or as a repeat array expansion as seen in the middle top. You can actually see the patient's DNA mapping to different chromosomes, which would be seen as a translocation, or it can actually be an inversion, where part of it maps to a distal region and the orientation is just inverted. So how do we tie this all in together? And where does optical mapping fit in with karyotyping FISH and CMA, which is what we do traditionally now in cytogenetics? Well, it goes back to the fact that the value of doing chromosome studies in neoplastic specimens has been realized for over 106 years. Initially by Boveri, who observed that solid tumors often had very abnormal chromosomal contents. So for the past 106 years or so, we've been analyzing and studying these various chromosome abnormalities. We've been cataloging them. And we know that when we do traditional clinical diagnostics, that we need to target both structural abnormalities as well as copy number abnormalities. And so current gold standards, cytogenetics requires karyotyping. We are faced with doing multiple rounds of FISH with different FISH probes. And more recently, we've added CMA, chromosomal microanalysis, which offers us a genome-1 scan. And now we can improve our resolution by looking for submicroscopic CNVs that cannot be detected, just visually by cytogenetic analysis. We can see all unbalanced abnormalities. CMA does not allow us to see balanced rearrangements, which is a critical aspect of cancer rearrangements. And even for the unbalanced abnormalities, particularly when there are many of them, we don't actually understand what the structure of the chromosomes are by doing CMA. And so a single technology that covers both structural abnormalities and copy number changes is highly desirable. And this is where I'll just temporarily segue to the Cancer Genomics Research Network. And this is an ad hoc network that I established with my colleagues of the CGC. It's established, essentially the idea was to establish a network that could help for rapid assessment of emerging technologies. There are multiple benefits of such a network. And just to list a few, starting off with the ability to do expeditious, access to very rare samples. Those of us in individual academic centers, we know that for rare samples, some of them may take months to get, or in some cases even many years. But by leveraging a network of colleagues, we can get a diversity of samples across multiple sites, and that includes rare samples. It also gives us the ability to spread costs, particularly when we are looking to do research projects. There's the potential for rapid assay validation, and even more exciting, it gives us the ability to assess clinical utility of new technologies, which would require collaboration of our local clinicians. And so a shout out to the current members of my ad hoc, CGRN network. Here you can see the Harvard group, Path group. I have colleagues at Columbia, Penn State College of Medicine, Mayo, the Seattle Cancer Care Alliance, MD Anderson, Augusta, and Legacy Laboratory Services. So as a first project of our network, we looked to assess optical mapping, particularly see its clinical diagnostic capabilities in cancer patients that have ALL and AML. The methods we are looking at blinded prospective, it would be blinded and prospective, comparing the results generated by optical mapping to results generated from routine clinical testing in a clear lab using current gold standard cytogenomic techniques. The primary hypothesis is that optical mapping will provide clinical diagnostic results in a single assay that would be concordant with those achieved using multiple gold standard technologies. And the secondary hypothesis, which I'm particularly excited about, is that we will uncover novel cytogenomic aberrations that will provide further insight into the pathogenicity of certain cancers, and this lays the groundwork for multiple future studies. Indeed, one of our members of our network, Jim Broach at Penn State College of Medicine, has now done a beautiful publication that illustrates many of these novel cytogenomic aberrations that are apparent using optical mapping. Phase 1 is a calibration stage where we were running samples that we knew, and we kind of used this to calibrate the assay. We're well into phase 2 now, which was assessment of blinded samples, which we would unblind and then compare to the gold standard. And for those of you that heard my talk at CGC, where we were excited back then, I just reported on the first 12 cases. We've now looked at over 100 cases, the majority of which have been run by Jim's group at Penn State College of Medicine, and about 25% at Columbia. And if we look at the preliminary results, which I'm going to show you for about 93 cases, just to mention, we are still doing a deeper dive into the bulk of this data set. But the first thing that you'll see at first glance is a very high concordance between optical mapping with karyotyping. We're seeing over 98% concordance. And if we look at in this data set, the two cases that were discordant, one CNV and one complex abnormality. A deeper dive actually of those specific cases, I believe, showed those abnormalities presence probably in less than 5%, you know, an allele fraction of less than 5%. And as we know from CMA, you know, when you have heterogeneity or mosaicism below a certain threshold, which is probably below 5%, the ability to pick those individual clones up becomes a lot more difficult. So very, very promising results from the get-go. I'm just going to spend the remainder of the talk illustrating exactly how this has been useful and how we've used it. So concordance with karyotype, and the most basic and simple example, if we look at our classic 922 translocation, this was a BALL case. And one of the ways we look at the data is first by looking at a circus plot, which basically lines up all the chromosomes in a nice circle. And if you follow at the very top where my arrow is, you start off on the short arm, the terminal region, those red kind of lines is where the centromere is, and all the way to Q-ter, that would be 2p-ter, all the way down to 2q-ter, etc. And what the circus plot will show you straight away is any type of rearrangement, which is shown by this kind of line connecting two chromosomes. And what you can actually see here is that's 9p. If you follow my cursor, and right at 9q, there is a breakpoint where a region is translocated to 22q. And if you follow that, it appears to be just underneath the centromere. So that 922 translocation is easily visible by optical mapping. But if we dig deeper into the actual mapping, and remember in the what you should be looking at is the patient's individual fragment of DNA, which is illustrated by that blue line. And here you can see that the region in purple maps beautifully to chromosome 9 from the patient, specifically at 9q34.12, which dissects the ABL1 gene. And then the same fragment of that patient DNA maps to a completely different chromosome, which is 22, at 11.23, again, right through BCR. And it's just such a gorgeous example of a translocation at the classic breakpoints, but now giving us gene level information. And again, that's the concordance that we saw with traditional cytogenetics. What about a study where the cytogenetics, at least karyotype, was normal? Again, if we look at the circus plot, you don't see any of those pink lines showing a rearrangement. So we saw nice concordance. There were even smaller intrachromosomal events. You can see these kind of dots all over the place, and you can see the color coding for that. But we need to review each of these smaller events for significance. And this is where those that have done constitutional microarray would have a great benefit, because many of these are just polymorphic gains and losses that we've seen. So those of us that have very nice CNV bed files, we can overlay with these and easily mask them out or rule these out very quickly for significance. But looking at chromosome 4 in this specific case, we see on the patient DNA mapping beautifully to chromosome 4. Again, I took the liberty of digitally splitting this to show the deletion, but that's what the actual individual molecule looks like. And so you can clearly see that middle region is absent from the patient region. And what we see is a TET2 deletion, which was indeed picked up by fish. Whoops, going back, was indeed picked up by fish. And just a beautiful illustration again of being able to find the things in a single assay. Looking at some other classic examples, here we have the inversion 16 in an AML case. And now if I zoom specifically onto chromosome 16, the circus plot, again, going from P to the centromere, and then through the centromere to the long arm of 16. And now if we look at what the software tells us, it indeed reveals a rearrangement from 16p to 16q, which is an inversion. And drilling down to the actual data, here we can see the patient in the middle, again in blue, mapping very nicely to the reference on 16, stopping at 16p 13.11, right through MYH11, and then continuing on a different region of chromosome 16 at Q2.2.1 right through CBFB. So very nicely seen, high concordance there with fish, where you can actually see the fusion of those two. Other rearrangements were in fact revealed. So we see a second translocation between 16p and 22q, as we see an even third rearrangement. It involves the same gene on 22q, but at a slightly different region of that gene. The optical map also gives us the ability to see deletions. And here we see a clear deletion from P12.3 to P11.2. And if we put this all together, again, looking at our concordance, here we have everything that was done by cytogenetics. You see the inversion, you do see a translocation that was picked up by cytogenetics, and you see the CBFB MYH11 rearrangement, as well as additional rearrangements that were detected using fish. We did get that all in one swoop using the optical map, but the optical map actually refined a second rearrangement, as well as a deletion that would likely have been picked up if you had used microarray. So what about the concordance with microarray? Well, I'm going to show you an illustration from one BALL case, and I'm going to specifically look at these three abnormalities that were picked up by chromosomal microarray on chromosome 7. And here we see the three that were indicated or highlighted by microarray. And if we look at the corresponding region shown by optical mapping, what you can see is that deletion of that one fragment on chromosome 7, which corresponds to TCRG. You'll actually see a second deletion, and that is seen from another fragment. And this again shows the ability to reveal the heterogeneity of different clones. We see a deletion on another region of chromosome 7, again covering the Icarus gene. And then we see a deletion of CDK6 as well, very easily ascertained by using optical mapping. For those of you interested in how the breakpoints are called in relation, so if we actually look at breakpoints that are called as well as the size, here we can see a very nice concordance between what's called by optical mapping and array. Remember, depending even on the array and how far apart your probes are, there are always going to be differences. Here's CDK6, again showing very nice correlation. And then TCRG, again, very nice correlation, although the significance of this deletion is not really clear. Another nice example is a homozygous deletion on 17q in another BLL case. Here we see the microarray data showing a 66 kb deletion of NF1, and there we see the deletion very easily by optical mapping. So in my last case, I'm actually going to show you how we can resolve a very complex karyotype with optical mapping data. And this was a BAL case. Here you see the full karyotype, and I'm going to work through this entire karyotype. So let's look at the optical map, and you can see a lot of things going on. Looks to be quite complicated, but let's do one abnormality at a time. So the lowest hanging fruit is the +8. And if you have a look at the optical map, it gives you almost similar to array data, gives you copy number data in this line. And there you can see, as indicated by the blue, a gain of the entire chromosome 8. So very easily see the concordance there. If we look at chromosome 5, we'll see there is an interstitial deletion, which on the optical map you can see over here. You can see this is the entire 5 starting from P to Q. So again, you can appreciate it that it is an interstitial deletion. And the optical map software also gives the ability, almost like an array, to see a whole genome view where you see the interstitial deletion on 5 very clearly, as well as the gain of chromosome 8 highlighted in that green and kind of reddy pink region. So that leaves the additional material on 17 as well as on 22 and the -20 that was seen by karyotyping. And you can actually say, well, what about that minus 20? If I look at chromosome 20, I don't really see a full deletion as was easily seen, let's say, with chromosome 5. There seems to be a very small focal deletion over there. And we'll get to that in a couple of slides. So let's focus on those 3 chromosomes, 20, 22, and 17. And let's look at what cytogenetics said was a Q13 gain. If we go to that region, we can see a deletion illustrated over there, as well as a translocation to 20q13.12, which means that this whole region of 20q13.2 is likely sitting translocated to q13.33. What about 20? We see an additional deletion. That means this entire region of 20 is missing. And now if we look at 17 at P11 or around there, what we can see kind of closely aligned at P13.1 is some copy number stuff going on over there. A deletion seen of the most distal region, and then a rearrangement from 17P13.1 to 20P11.21. So again, we have an unbalanced rearrangement with that part of 20 sitting on 17P. And so you could say, you know, why did cytogenetics kind of get that wrong, so wrong? Because that's 1.2. But if you start appreciating the complexity of this, you'll realize that this is an extremely difficult call. To verify this is indeed a rearrangement, here we can go to chromosome 17, and again, here's the patient in blue, and let's see how that all maps out. So those regions on 17 map to 17P13.1, but the continuing region maps to 20P11.21. So verifying that is indeed a translocation. So now what we have for both of those, instead of an add 17 or an add 22, is a derivative, understand exactly where that region of chromosome 20 disappeared to. And again, we can see added complexity on chromosome 17, giving us a better understanding of why it was so difficult by cytogenetics to call that breakpoint. So what about the loss of 20? Well, it's easily explained when we put all those regions of 20, that region in yellow that has gone to 22, that region in the middle that has disappeared, and the region at the top there that has gone to 17, which only left us with that small region on 20, which probably would have been seen as a marker chromosome. But now when I show you the additional complexity that was seen, we know in fact that those regions that were left are somehow intertwined with 17P. So really nice example of how we can resolve that karyotype. So just to summarize, it's optical mapping as a very powerful new cytogenomics tool for assessing chromosome structure and copy number. There is tremendous and remarkable concordance with traditional cytogenomic analysis for the karyotype, FISH, and microarray. It gives us additional clinically useful information to existing karyotypes and FISH. So hopefully I've demonstrated how it can resolve complex rearrangements observed by G-banding. It reveals partner translocations, the chromosome or the gene fusion. We had 2 cases last week, one where we saw the NPM1 MLF1 translocation that was not seen by FISH, as well as a MECOM ETB6 that was not uncovered by FISH. We only saw one of the partner. It does provide additional new information not revealed by standard cytogenetics workup. So as a new tool, we need to thoroughly investigate its potential and limitations, compare to alternative technologies like MatePair, and we're working with the Mayo Clinic, Linda Bourne's group, and Beth Patel have done a wonderful job working with us. We have 2 cases that we're working through right now. We need to assess reproducibility, understand the QC metrics that yield reliable results, and eventually move into the discovery phase where we're assessing samples deemed normal by karyotype and traditional methods, and try to get an understanding of whether there are recurring abnormalities, what the prognostic value is, and whether there's any therapeutic value. And this is going to require long-term collaboration with clinicians. So I do need to acknowledge a good number of people, as as we've seen over here. I don't have enough time to mention everyone independently. I'm going to stop there. We'll take questions at the end of Rashmi's talk. And so I thank everyone for their attention, and I am going to hand over to Rashmi.
Hello, everyone. I hope you can hear me. Thank you for joining us this afternoon. Thank you firstly to Gordana for the kind introduction at the beginning of this session. And thank you, Brynn, for that fantastic talk and for introducing the technology. So in this session, my talk is focused on the application of optical mapping in assessment of structural variants for clinical diagnosis and management of myelodysplastic syndromes. And in our lab 3 months back, we actually, based on our preliminary experience with the technology, we set up the instrument in our lab, and we were able to successfully test some of our samples. I guess this was before the COVID shutdown, and I would like to share some of those findings here as well. So as we know, structural variants are very important for diagnosis and prognosis of hematologic malignancies. Structural variant knowledge is as important as mutation, sometimes even more. So unfortunately, unlike the point mutations that can be identified by next generation sequencing technologies, the high throughput techniques for detecting structural variants have not been at par. So the structural variants includes both the copy number changes as well as gene rearrangements. And at this time, in order to identify these abnormalities at a fairly high resolution, we need to adapt multiple technologies that includes the karyotype, FISH, microarray, etc. And each of these have different limits of detection. And assessment of structural variants by NGS is still in the primitive phase, and it's not yet mainstream in the clinical realm. And so, since optical mapping has the potential to identify it could be a single platform for identification of all different types of structural variants, and hence that is what piqued our interest in this technique. Now, why did we select myelodysplastic syndrome for our study? So as we are aware a little bit about myelodysplastic syndrome, so MDS, it's a group of clonal hematopoietic malignancies that's characterized by cytopenias, dysplasias due to ineffective erythropoiesis, and a propensity for development of acute myeloid leukemia. Now, MDS, the outcome of MDS cases are pretty heterogeneous, and it's primarily driven by structural variants. And hence, the structural variants play a very important role for risk stratification of MDS, and based on which the treatment strategies are decided. And we also know that MDS is a precursor to a significant proportion of acute myeloid leukemia cases with cytogenetic aberrations. And optical mapping could provide us a way to understand the karyotypic evolution at a fairly high resolution. To elaborate more, so nearly 50% of MDS cases have structural variants, and this would be in a de novo setting. If the MDS arises in a setting that is therapy related, which means the patient has received a prior chemotherapy or radiation for a different cancer, 90% of those cases have structural variant. And some of these cases are considered to be disease defining. Normally, the diagnosis of MDS is made based on morphologic assessment of dysplasia, to be seen in at least 10% of the cells from any of the 3 lineages. It could be granulocytic, erythroid, or megakaryocytic lineages. But sometimes the morphologic assessment can be quite challenging. This is especially the case when the dysplasia is very subtle, or if the quality of the specimen is limited, which can happen quite frequently in a clinical setting. And it's in these diagnostically challenging cases, now identification of some of the structural variants that are characteristic of MDS can be extremely helpful for the pathologist to make this diagnosis. So you can see here the abnormalities that are listed here in this table. These are regarded by the WHO guidelines as presumptive evidence of MDS in any patient with unexplained cytopenias. In addition, the specific types of structure variants are actually behave differently, and they are considered to be different biologic entities. For example, if there is an isolated del5q abnormality, it means that this patient will likely respond very well to lenalidomide therapy as opposed to other different types of therapy. So, despite identification of a large number of gene mutations and molecular aberrations, as I mentioned, the outcome of MDS, it's primarily dictated by the relatively larger chromosomal changes, and that's detectable by karyotype and other techniques. So based on the association between different types of chromosomal abnormalities and the outcome in MDS in a large cohort of MDS patients, a cytogenetic scoring system has been developed that is supposed to classify the chromosomal changes into 5 separate categories. So very good, good, intermediate, poor, and very poor. So as you can see, this includes not only the number of cytogenetic abnormalities, but also different types. And that include copy number changes, and you can see several translocations as well. So combined with the blast percentage, the degree of cytopenias, and this cytogenetic score, the model, which is called the revised IPSS risk stratification model, this is a universally used model for treatment decisions in myelodysplastic syndrome. And at this time, conventionally, these abnormalities, the cytogenetic abnormalities have been, this model has been determined based on the abnormalities detected by karyotype alone. But we're now aware that there are several other technologies that can pick up cryptic abnormalities. And some of these abnormalities could be submicroscopic beyond the resolution of karyotype. And at this time, we are still not sure what is the clinical significance of these abnormalities. And the optical mapping technology will provide us a good opportunity to explore this. So last point I want to make regarding the MDS is, although majority of MDS cases have copy number changes, there are some critical gene rearrangements that can happen in this condition that is very important for prognostications. And these include EBI or MECOM gene rearrangement, MLL gene rearrangements. Now, in some cases, these rearrangements can be cryptic by karyotype, and they can even occur in a non-complex setting and can be easily missed unless we do a targeted FISH. Now, the other case is sometimes the core binding factors such as translocation 821 or inversion 16. These abnormalities can present with low blast percentage associated with dysplasia, leading to a misdiagnosis of MDS, although these are to be considered as oligoblastic AML. Now, the importance is that these oligoblastic AMLs have completely different therapy. They have a very good outcome, and they respond very well to cytarabine-based consolidation therapy, unlike myelodysplastic syndromes where the standard of care is hypomethylating agent. So a comprehensive platform with a comparable resolution that can identify all different types of structure variants is extremely valuable. So that is why we chose MDS. So the objectives of this talk is threefold. So is optical mapping able to detect known structure variants in MDS? Number 2 is, are we able to uncover any new aberrations, and are these clinically relevant? For example, are they prognostic, or do they change the IPSS risk score, etc.? And the third question, this is more of a long-term in-process question, is do these new genetic aberrations identified by optical mapping alter outcome in clinical trial setting? So as I mentioned, 3 months back, we in our lab, we were able to set up the Sapphire instrument to perform optical mapping on our samples, clinical samples. And since then, with the support from the BioNano group, as well as our IT department and our lab has been able to run a few samples successfully. Now, during our initial phase, we wanted to explore different types of sample to see what works best and if it's even feasible for clinical workload. So we've used the frozen cell pellets from bone marrows that these have been frozen over the last couple of years. We've used the live bone marrow. Actually, some of the frozen cell pellets we used have gone back to as far as 5 years. So we've also used live bone marrow mononuclear cells that have been preserved in DMSO. We've also used fresh and 48-hour-old flow specimens from our clinical labs. And all of these samples have yielded successful results as long as they met the 2 minimum criteria. This is the number of cells to begin with had at least 1 million cells, and a minimum DNA of 36 nanogram per deciliter was obtained. So the workflow is pretty straightforward, and we found that the workflow was pretty compatible for a clinical lab. So the day one is primarily isolation of high molecular weight DNA. One point I wanted to make is, since we have to work with long molecules, nearly 150 kilo base pairs, longer than 150 kilo base pairs, and these molecules have to be assembled in order to generate the complex repetitive genome, it is important to actually process these samples in a very gentle manner, and also to preserve these samples to be these are extremely delicate. The day two was primarily quantification of the DNA and direct labeling and staining. Day three was quantification of labeled DNA and to load the Sapphire chip and to start the overnight run. And day four was primarily analysis. So our analysis, we did it using our rare variant pipeline. And in order to rule out any constitutional aberrations, we also had 200 healthy controls, data from 200 healthy controls, and that facilitated the detection of the somatic variants. And the limit of detection, as determined from prior sensitivity studies, was about 95% for structure variants with an allele fraction of 10%. So in total, we have analyzed 13 samples, and together they had 40 aberrations detected by conventional karyotype, and 9 of these samples had cytogenetic aberrations by karyotype, and 4 were of normal karyotype. And when we analyzed them using optical mapping, 39 of 40 aberrations were identified by optical mapping, and that's a 97.5% concordance. And all of the aberrations that were detected by microarray was confirmed by optical mapping. That's 100% concordance. Now, the one aberration that was missed by optical mapping was on chromosome 7q deletion, and that was identified by karyotype, but was missed by optical mapping. So when we did the FISH on this sample, it showed that the percent abnormality was 7%. Only 7% of the cells showed this abnormality. So we believe that the karyotypic aberration that was detected may have been related to proliferation bias. So in the next few minutes, I would like to show you some of the cases that we have actually, the results of some of the cases that we selected samples that we found were of interest and that actually had a clinical significance. So this is case 1, MDS with 2% blast, showed deletion 5q and an addition on chromosome 12p13. So deletion 5q we know is a frequent recurrent abnormality in MDS. And here's looking at the circus plot, and we indeed see a deletion 5q. We also see it as a structure variant because it is a fusion. It's considered as a fusion between the remaining fragments. And in addition, there is a translocation that is occurring between chromosome 1 and chromosome 12. Now let's dig in deeper to chromosome 5q. We are able to map the deletion between chromosome 5q11.1 to 5q35.2. We are also able to see that in the by visualizing the genomic fragment in the lower panel. And you can see the fusion fragment. These are actually genomic fragments that have undergone alignment with the reference seen above. So the focus of interest here is the fusion of the remainder of the 2 fragments of the chromosome 5, resulting, which is consistent with the deletion. We can go in further at the level of the genes, map out the genes that are actually deleted, in addition to several genes that are deleted as a result of this aberration. We also see that this particular gene has been disrupted because of the deletion. And so now that the deletion 5 is clear-cut, let's explore further into the translocations that we see here. Now we can modify the circus plot here to include only the relevant chromosomes, that is chromosomes 1 and 12. So it is very clear here that there are indeed 2 translocations. And in addition to that, there is a copy number gain in chromosome 1 and a subtle copy number loss on chromosome 12. This is confirmed in the lower panel, as you can see in the copy number track, the deletion on chromosome 12. So here is actually zooming into that area where of the fusion product between chromosome 1 and 12. So here is what we see, this part of the product maps to the chromosome 1, and here is the product that maps to the chromosome 12. And we still see a fragment, the portion on the product that is mapping to neither of these genes. Upon further investigation, we were able to identify that this fragment mapped to chromosome 5. So this is actually a complex derivative chromosome that was obviously missed by other technologies. So here is the second case. This was a therapy-related myelodysplastic syndrome with 2% blasts, and karyotype showed translocation 911 and deletion 20q. Now deletion 20q we can see from the circus plot, and we are able to confirm it on zooming into the fusion product as well. In fact, in the copy number tracked up in the upper panel, we see a deletion, and we see that there is some degree of heterogeneity here. We see a large deletion spanning from one end to the other, and within that there is a second deletion in a subset of cells. And this is very important, and it's actually highlights the ability of this technology to identify clonal heterogeneity, which is implicated in the resistance and relapse in these conditions. Now going to the translocation 911, we've zoomed in, we can identify, we can map the translocation breakpoints here. In addition to the translocation, we see on chromosome 11 that there is a deletion beyond the translocation. Now, when we looked into it, the deletion, the one important point I want to make is the translocation breakpoint. The translocations did not involve MLL gene or KMT2A gene. That's important to know because when in a therapy-related MDS setting, the KMT2A translocation has an extremely poor prognosis, and it's most likely the abnormality. But this was interesting in that it did not involve KMT2A. But even though that was not involved in the translocation, KMT2A was involved in the deleted region here. And we subsequently performed the FISH, and we confirmed that there was indeed a deletion of MLL and absent translocation. Here is the same case. In addition to the deletion 20q and 911 translocation, we can also see that there's a fusion between chromosome 4 and 7. That is confirmed on the bottom panel, the translocation. In addition, the copy number track shows a deletion on chromosome 4. So we went in further and we see that we mapped the genes that were involved in this deletion on chromosome 4 that was cryptic by karyotype. And we noted that one of the most important genes involved in myeloid malignancies, the TET2, was deleted in this. So the deletion of TET2 is a very significant finding that has clinically relevant information. This case at the same time underwent an 81 gene panel, the next generation sequencing panel, and that had showed SF3B1 mutation and a TET2 frameshift mutation. So putting everything together, this patient has a biallelic loss of function in TET2. Now this is in MDS is quite significant. There is data suggesting that TET2 deletions have actually increased the responsiveness to hypomethylating agent therapy. Now here is case number 3, which is a case of MDS with diploid karyotype. By optical mapping, we identified a 174 kilobase pair deletion on chromosome 11, and this did not involve MLL gene. Now, as I had mentioned before, the cytogenetics scoring system that is used for IPSS risk stratification, I have just zoomed into it. You can see here that a diploid karyotype is considered as a good prognosis, falls into the good category, whereas deletion 11q falls into the very good category. So this identification of this cryptic deletion 11q changed the IPSS risk score in this patient, and that is extremely significant. Now, here is another case that we did. This is actually a case of AML that had a history of low-grade MDS before. The karyotype showed addition on chromosome 5q22, and by NGS, the patient had an SF3B1 mutation. Now, based on the circus plot, we see a translocation between chromosome 5 and 6. That's also confirmed here in the right panel. In addition, you can see, if you zoom into chromosome 6, there is gain of chromosome 6 in the chromosome 6p region that is not picked up by karyotype. Now, this is again a significant finding. When we did a little bit of literature search, and we found that genomic gain on 6p21, it's actually cryptic molecular rearrangement, and it's implicated in secondary AML transformation of MDS cases. And in fact, 6p gains are considered as major pathogenic events in these cases. And finally, this is another case. I still have 2 minutes, so this is another case I wanted to present. It is another case of AML that arose from an MDS patient. The karyotype showed a new abnormality of inversion 3, and we can beautifully see that in the optical mapping here as well. So overall, based on our preliminary analysis, we found that there was a very high concordance between the results of optical mapping and the other gold standard clinical diagnostic assays. And the optical mapping is a pretty high throughput technology with a limit of detection of about 10% that is compatible with the clinical needs. And it can, in fact, identify many aberrations that may change the RIPSS risk score for MDS cases. And based on our own experience with the implementation of the instrument in our lab, we've seen that it is very compatible with the clinical workflow at this stage. And we are we have collected nearly 100 additional samples of myelodysplastic syndrome in our lab, and we're waiting for our labs to reopen. Hopefully, we hope everything will go smoothly, and the lab should reopen in a month or so. And we plan to test all of these samples primarily with 2 goals. So firstly, we would like to identify any cryptic genomic aberrations and see and assess the clinical significance, if they are diagnostic, prognostic, or if they alter the IPSS risk score, and if identification of these abnormalities in fact changes the clinical management. And second goal is to actually assess the treatment response in a clinical trial setting. So with that, I wanted to acknowledge our Department of Hematopathology led by Dr. Medeiros and section of Molecular Diagnostics led by Dr. Luthra, who have supported this. And I also wanted to acknowledge the Department of Leukemia, Dr. Garcia Monero and Hui Yang, both of who have supported and assisted with this setup. And that concludes my presentation. I'm open for any questions.
All right, thank you too for wonderful presentations. We are at the top of the hour. I just want to say our code, because it came to my attention that some people are listening and not seeing the presentation. The 6-digit code is DUTSES, and you can text that to 608-260-7097 in order to claim credit for this presentation. I would like to take one or two questions that came up several times in the question box. And this is for both of our presenters. You can chime in at any time. But number one is just talk about the overall cost of optical mapping and how much it is per sample. And as it stands now, is it currently a feasible clinical test in terms of cost, reimbursement, and turnaround time? I think so, yeah.
Okay, I didn't know whether Rashmi was going to take that or whether I was going to take that. And I should just acknowledge the Bionano folk who anticipated this, because obviously this is something that we get from them. And a quick summary of the costs is, I think for a full service run at Bionano, they do it $650 for constitutional and $750 for cancer at 400 times coverage. The reagent rental program that they do is $550 per genome. And well, there's obviously all the different costs for the equipment, but I think they are trying to get the cost down per sample to under $100 in the next 2 to 3 years. That's, I believe, their ultimate goal.
Great, thank you. Can you talk about the requirements regarding DNA quality and what your DNA input is for optical mapping? And is it possible to use DNA extracted from FFPE tissue or other types of samples?
So with such an amazing ability of the technology, it's one disadvantage is the fact that you do require very long DNA molecules, as I showed you in the beginning. And that's the way that the longer it is, the easier it is to align and map. And so the disadvantage is that you cannot take archived DNA, and that means just genomic DNA, and even less so, FFPE extracted DNA, which typically has very, very short fragments. I don't know if Rashmi wants to add anything to that.
Right. Thank you, Brynn. So the DNA, we found that at least we need 36 nanogram per deciliter. And if we get that, we are able to proceed. And like Brynn mentioned, yes, we cannot use the highly fragmented. So as I mentioned, we need really long fragments, and FFPE would obviously fragment the DNA enough that we are unable to use that for optical mapping.
Okay. What would you say would be the lowest level of mosaicism which can be detected? Rashmi, you mentioned a experiment where you had structural variants that were missed because the fraction by FISH was 7%. Would collecting optical map molecules at a higher coverage reveal the structural variant?
Yes, I personally have not performed the experiment yet, but by talking with the Bionano folks, we are actually working. So if we run the sample so right now we do it at 400x, and the limit of detection is 10%. And if we run it in 3 cells, so that would be a 1200x coverage, would, proof of principle is that it could generate much lower calls and go down up to 1 to 2%. But I personally have not done that experiment to say that, but technically very much possible, and BioNano folks are exploring that.
Great. And then could you tell the difference between the breakpoints for BCR-ABL, the minor versus major? I think this is for Brynn.
So, I mean, the beautiful aspect of this is that the breakpoints are going to be aligned to the closest tagged site. So it gives very good resolution of all the breakpoints that are there. So I believe yes would be the answer. I don't know if Rashmi, do you see any reason why it wouldn't be able to?
I guess I've not run a BCR-ABL case, but if you're able to go down to exon level resolution, could be, yes.
Okay. And then how about methylation, DNA methylation? Does that alter the binding of the dye? And are there methylation specific dyes that can be used?
So that is beyond my knowledge base. I think I would either refer you to Rashmi if she knows the answer, or refer you to the BioNano folks.
No, I don't. If it's beyond your knowledge base, it's beyond mine too.
Okay, and then just one last question. I don't know if I personally missed it, but is it possible to use this to detect copy neutral loss of heterozygosity?
So unfortunately, that does require known sequence. It's hard. I know we get such amazing resolution and we're talking about specific genes down to the actual gene level, but it's actually maps of the entire genome. It's a visual map. And so we are not getting base pair information. So the answer would be no.
Okay. All right. Well, that concludes our webinar, and I hope everyone enjoyed, and we'll tune in next month. Thank you again.
Thanks a lot to our speakers for wonderful talks.
Thank you, Gordana.
Thank you, guys.
Thank you.
I hope to see everybody next month.